Coming up in this episode, it's essential that the joint is relaxed. And the key here is to ask the patient to drop the shoulder. So if they're actively elevating their shoulder, so they're activating their trapezius and they're therefore also flexing and activating their triceps muscle and flexing their elbow, and they've got their arm all stiff like this, then it's unlikely to be effective. Hello, and welcome to the next installment of Restored Neurology Education, a not-for-profit, free open access project with a philosophical touch exploring all areas of clinical neurology, meant for medical students through to neurologists and everyone in between, and really all health professionals involved in the care of patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, a neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today, we have another entry in the clinical method series titled Upper Limb Neurological Examination, the Theory, with Pearls and Pitfalls. Before we dive into it, a legal disclaimer. The content of this episode is for educational purposes only. This episode is going to be discussing the upper limb neurologic examination. To begin with an overview, there's a routine assessment that I do for every patient that I see in a neurological context. And then there are some additional components to the examination that I do on a case-by-case basis. This video is going to be over the routine assessment that I do for everybody. And then there will be additional videos for some of the other special contexts where there may be additional tests that I would do. So the overview of what we'll be talking about today is initially positioning and exposure. So it's easier sitting the patient on the side of a bed. Lying on a bed is also fine. Sometimes standing is okay, but it's not optimal. Then we'll be talking about inspection and palpation, tone, power, reflexes, sensation, which consists of pinprick and or temperature testing, vibration sensor and or proprioception testing, and sometimes light touch and 2-point discrimination testing, and also neglect testing, and then coordination testing. The components that will be discussed in other episodes, which is relevant to the upper limbs, is other extrapyramidal testing, such as testing for bradykinesia, tremor, frontal release signs. That will be discussed in the extrapyramidal episode. And then other components of neuromuscular testing, for instance, fatigability if you're suspecting a neuromuscular junction transmission defect, such as myasthenia gravis, testing for grip and percussion myotonia if you're considering a myotonic dystrophy, some specific aspects of power testing that we don't routinely do for everybody, such as isolating specific muscles in the context of abductor pollicis brevis APB testing, or brachialis and brachioradialis testing by testing elbow flexion in pronation as opposed to in supination. There are some examples of specific power and other forms of assessment that we would do in a neuromuscular context if you're in a neuromuscular clinic, or if you're suspecting a patient has a myopathy or a specific plexopathy or something along these lines. There are some additional tests that you may do as well. But we're going to be talking about the core component of the upper limb examination that you will do for most patients, and it covers almost everything. So, firstly, inspection and palpation. The patient needs to be adequately exposed, at least from the shoulders down. Ideally, and if you're in an examination setting or if you read the textbooks, they'll say really the whole upper body should be exposed. You should be able to see the pectoralis, the back muscles. You should be able to assess for winging of the scapula, etc. That is very important in a specific neuromuscular context, but I'm not sure it's entirely necessary to get the patient completely undressed and shirtless if you're doing an epilepsy assessment or a headache assessment. So you need to pick the patient and do what's appropriate on a case-by-case basis. Then what are you inspecting for? So you're inspecting for wasting, firstly, and you want to note the distribution of the wasting. Is it bilateral? Is it just affecting one muscle? Is it affecting a group of muscles? Can you group them anatomically in some way? Is it affecting the flexor compartment or the extensor compartment? And one particular pattern to look out for, more so in the neuromuscular context, is does the patient have a split hand? So what that is when there's thenar eminence and also FDI, first dorsal interosseous wasting. So they're on the lateral aspect, on the volar and dorsal aspect of the hand, respectively. If they are wasted, but there is relative sparing of the hypothenar eminence, which is in part made up by the abductor digiti minimi muscle, the ADM, then you can get the instance in which the patient looks like they have a split hand. So the medial aspect of the hand is not wasted and the lateral aspect of the hand is wasted. And that's one characteristic finding in amyotrophic lateral sclerosis, ALS, or motor neuron disease as a larger umbrella term, so MND. And one way that you can remember this as to which one is which is you can remember this concept of the split hand index, which is a neurophysiological principle that we'll talk about more in some of our neurophysiology episodes. But basically, you're comparing or you're looking at the CMAP, so the compound muscle action potential, the CMAP, of those three muscles, APB, the FDI, and the ADM. And then there's this formula where you multiply the APB by the FDI, and then you divide that by the ADM. So you're basically getting a ratio between the product of the APB and the FDI compared with the ADM. And that's a quantitative numerical way that you can actually measure this wasting on this split hand, and it can be part of a diagnostic evaluation for ALS. Obviously, that's a bit more advanced, but it's just an example of the sorts of anatomical patterns that you're looking for when you're evaluating for someone with wasting in the upper limb. The next thing that you want to inspect for is fasciculations, and this is very important. And you have to look for a sufficient length of time and at a sufficient range of muscles or at different parts of the upper limbs on both sides to really see fasciculations. And depending on the clinical context, you might want to have a really good look. So if you really think that the patient has ALS, for example, you don't want to have a glancing look for 5 seconds. You might really want to look for half a minute or a minute. So I'd recommend having a good look for 15 to 30 seconds, having a really good look for fasciculations in most contexts. If you don't see them, what you can then do is you can try gently flicking the muscle, so just doing like a little flick on the muscle, and not uncommonly that will then bring on fasciculations that may not have been there previously. Then there are some other aspects of inspection and palpation that I wouldn't routinely do, but I may do in some contexts. So in more of an extrapyramidal context, there's many other tests you would do. And of course, if someone has obvious involuntary hyperkinetic movements like a tremor, then you'd make note of that. Palpation is more of a neuromuscular context test. So you're palpating for muscle swelling or tenderness, which may be relevant in some metabolic myopathies in particular. And also, you'd want to make note of any obvious cutaneous lesions, for example, neurofibromas, although you could also classify that as more being part of a more systemic or general assessment. But if you're examining the upper limbs and you see some neurofibromas or cafe au lait marks, then of course you should take note of that. Now, tone. How do you actually examine tone? So there's a few joints that you should be moving passively. There's forearm supination and pronation, wrist flexion and extension, as well as just elbow flexion and extension. So it's not sufficient just to do elbow flexion and extension. You really need to do the supination, pronation, and the wrist flexion extension as well. And you're assessing it through a range of movements. So you're not just assessing it through a partial range of movement of the joint. You should be assessing it through the whole range of movement of the joint. And this is very important. It should be assessed using a range of velocities. So you should move the joint slowly and then quickly and through a different range of velocities. Why is that important? Well, when we're assessing tone, if the tone is increased, so hypertonia, PER tonia, you then need to determine whether the tone is spastically increased. I know that word has been misappropriated and can be a bit of a taboo word in the wrong context, but it is a medical term. So if the tone is spastically increased, then that means that it's in an upper motor neuron lesion pattern. And what that means is it's velocity dependent, and it's often been described as a clasp knife pattern. So what that means is when you move the limb quickly, you get lots of hypertonia, and then you may get this give way where the hypertonia then gives away and it becomes less hypertonic. Conversely, if you're just moving the arm slowly, you might completely miss it. So the hypertonia may not be as pronounced or apparent at all when you're moving the limb slowly, but then when you move the limb quickly, you then suddenly get this burst of hypertonia. That is in contrast to lead pipe rigidity, and that is velocity independent because you will find that the limb is just stiff the whole way throughout the movement. So it doesn't matter if you're moving it slowly or quickly, it's just going to be stiff and hypertonic the whole way through. And that's in an extrapyramidal pattern, so classically in the context of Parkinson's disease. And if there is a superimposed rest tremor, then you may get this cogwheeling feeling. So it's as if you're pulling a cogwheel, and that's why it's called cogwheeling rigidity. Now, importantly, when assessing for increased tone, particularly in an extrapyramidal context, if you're not identifying the increased tone, it's important to distract the patient. So you can do that by asking them to turn their head side to side. That's what I like to do. Or alternatively, you can ask them to make circles with their contralateral arm, like this. Or you can ask them to perform some cognitive tasks, for example, saying the months of the year backwards. And that can be really, really effective in bringing out subtle hypertonia, which was not there without the distracting maneuver. And the same is true for tremors as well. Now, the assessment of hypotonia, P-O-tonia, is a bit trickier because the presence of hypotonia is not always abnormal, particularly in young, otherwise healthy patients. So you do need to interpret this with the other signs that are present. So if you have someone who's young and healthy, maybe you're seeing them for a seizure or for migraines or something not really related to the extrapyramidal or the neuromuscular system, and they have some isolated symmetrical hypotonia, and there's no other abnormal neuromuscular neurological signs identified, then it's probably completely insignificant and it's probably within normal limits. Conversely, if you have a patient in a different context or a patient who has a combination of hypotonia and hyporeflexia and weakness, then that's clearly significant and that's clearly abnormal. And of course, it's in keeping with a lower motor neuron lesion. The exception there is in the acute phase of an upper motor neuron lesion, you can have a hypotonia pattern initially, but then after a period of time, it then converts into the more classic hypertonia, the upper motor neuron pattern of weakness. So, speaking of weakness, let's move on now to power. So, what actual movements do I perform routinely in my power assessment? Well, I do shoulder abduction and adduction, elbow flexion and extension, wrist flexion and extension, finger flexion and extension, and abduction. Now, there are going to be additional muscles that you will test in a specific neuromuscular context. So, for instance, you may wish to isolate the distal interphalangeal joints when testing finger flexion from the proximal interphalangeal joints, because we know that the DIPs are controlled by the FDP, the flexor digitorum profundus muscle, whereas the PIPs are controlled by the flexor digitorum superficialis muscle, and they have different neurological supplies. And I did mention a few other examples in the introduction to the episode as well. So isolating the APB in a median neuropathy or in some other process involving the median nerve, or isolating the brachialis and brachioradialis muscles to distinguish their power compared with the biceps brachius power. One other test that you may consider doing is testing for pronator drift. So some people use this just as a screen for upper limb power and then don't examine the rest of the power, which I would not recommend. And some people recommend doing pronator drift testing in addition to testing all of the other muscles. And the rationale for that is that pronator drift is more sensitive for subtle weakness, predominantly for upper motor neuron weakness. So even if you score 5 out of 5 power for each individual joint, it may be the case that the patient still has some subtle pronator drift. So if you have clinical suspicion for a subtle degree of upper motor neuron weakness, but despite that, the patient has 5 out of 5 power testing in the upper limb, then it probably is reasonable to test for pronator drift in case there is subtle pronator drift indicative of subtle upper motor neuron weakness. But if that's not really what you're considering, or if you've already demonstrated that there's weakness in the upper limb, then there's little to be gained additionally by doing pronator drift testing. One other point I'll give in regards to testing power is that you generally want to test the power for each joint somewhere around the middle of the range of movement of that joint, as opposed to at the extremes of the range of movement for that joint, because that can create the impression of weakness when it's not actually weak. So, for example, you want to test elbow flexion with the elbow flexed in the mid position, so at about 90 degrees. Compare that with if the elbow is already almost completely flexed before you even begin to test the flexion power, then the elbow doesn't have far to move and it might appear weaker than it actually is. Or conversely, if the joint is completely extended, it can be hard to get started. So if you test elbow flexion, it might seem a bit weak in that context as well. So you really want the joint to be in about the mid position of its range of movement and then test the movement. That's also convenient because you can test the movement in the opposite direction as well. So you can test flexion in that position and then quickly test extension in that position. And of course, we're comparing side to side with our assessment as well. So how do you actually score power? Well, we use the MRC, the Medical Research Council grading system. 5 out of 5 is normal. Some people use 5 minus, and I actually do like using 5 minus. So what 5 minus is it's borderline normal, but it's mildly asymmetric. So in normal circumstances, you call it a 5 out of 5, but you've identified that it's slightly asymmetric compared with the other side anyway. So that's then a 5 minus out of 5. And I do think that that can be quite useful. Then you've got 4 plus, which is quite strong, but can just be overcome. 4, which is there's some strength against resistance. 4 minus, which is that there is a minor degree of strength against resistance. 3, which is there is anti-gravity strength, but there is no strength at all against resistance. 2, which is movement with gravity eliminated, but no anti-gravity movement present. And in order to test that, you need to position the joint so that it's not fighting gravity when you're testing it. So you, by definition, cannot ascertain that someone has 2 out of 5 power with elbow flexion if you have the arm orientated such that the elbow needs to flex against gravity. So you actually need to position the limb such that the flexion is with gravity eliminated to score it a 2 out of 5. Then a 1 is if there is a flicker of movement only, but it's not completely plegic. And then a 0 is if the limb is completely plegic. It's important to note that very, very, very minor 5 minus out of 5 asymmetry in a non-dominant limb is not necessarily abnormal. It's also worth noting that some people break down the scores further. So I've seen people write 3 plus and 3 minus, for example. I really don't like those additional delineations. I think they're confusing and they don't really offer much, and I don't really think that they're necessary. So I'd recommend sticking with the ones that I've just discussed with you. The main trap that I see people falling into when they're assessing MRC grading for their power assessments is using an inappropriate amount of force yourself. And the main mistake is people using an insufficient amount of force. So you actually need to use more force than you might think. It can be surprising to some. And that's especially true for proximal joints. Lots of people underdo it and therefore incorrectly grade the patient as having more power than they actually do. So you have to press pretty firmly to try and overcome the joint. I've only seen the opposite done once, where the person was applying a ridiculous amount of force, in my opinion, and it actually resulted in a muscle tear in the patient. So that was not good, and I would strongly recommend against that. But I've only seen that done once. It's much, much, much more common for people to apply an insufficient amount of force. So make sure you're doing enough force. For distal joints, of course, the amount of force that you apply needs to be proportionate to what would be a normal strength in that distal joint. So in the upper limbs, I actually like to use my own distal joints when assessing it. So when I'm testing the patient's wrist flexion and extension, I use my own wrist flexion and extension to push against the patient. And when I'm testing their finger flexion and extension and abduction, I use my own fingers to push against the fingers of the patient, just so that I know that I'm applying an appropriate amount of force. Next is reflexes. And the main point that I would give here is that it's all about positioning, positioning, positioning. It is much, much easier to assess reflexes with the arms in a nice, relaxed position. And if the patient's sitting, then it does really quite help a lot by having the arms nicely supported on a pillow. The other main tip is to have the right equipment, the right tools for the job, and it really helps to have a big tendon hammer. So by big, I mean the head of the tendon hammer is bigger than the standard ones. I went through all of medical school and all of my junior doctor years using the standard small tendon hammers, and I only converted to the big ones about 4 years ago when I first began my advanced training in neurology and then more recently working as a neurologist. And I can't believe that I went so long without using them because they help so much. I got mine from bigtendonhammers.com. I'm not affiliated with them in any way. I just think it's a funny URL for a website, and they're not too expensive, or you can get them from anywhere else. The reason they help is it's a lot easier to apply a sufficient force to elicit the reflex with the bigger tendon hammer. And the other reason is that's especially important in a patient with increased body habitus, so in an obese patient. And it's especially true for some of the lower limb jerks, but it's also true for the upper limb jerks. Now, in terms of tips for eliciting each of the individual reflexes, the biceps jerk I find easiest to elicit when the elbow is flexed to about somewhere between 90 and 135 degrees, so like this. And I usually place my middle and index finger over the biceps tendon and then strike my fingers with the tendon hammer. Regarding the brachioradialis, similarly, you want the joint positioned in the same degree of elbow flexion. And then regarding supination and pronation, you want it to be in about the mid position. So you don't want it pronated or supinated all the way. You just want it in the mid position partway through supination and pronation. And again, I place my middle and index finger over where I'm going to strike and then strike my fingers so that it's not painful for the patient. Regarding the triceps jerk, this can be tricky if you're not doing it correctly. So it's essential that the joint is relaxed. And the key here is to ask the patient to drop the shoulder. So if they're actively elevating their shoulder, so they're activating their trapezius and they're therefore also flexing and activating their triceps muscle and flexing their elbow, and they've got their arm all stiff like this, then it's unlikely to be effective. So if you ask them just to relax their trapezius muscle and drop their shoulder, and if you have a pillow so that their arm is just completely passively resting on the pillow and everything is nice and loosey-goosey and floppy, then that's the key there. And then you just want to palpate the distal part of the triceps tendon where you want to strike, and then strike it. I just strike the tendon directly. I don't strike my own fingers. In some circumstances, mainly in a neuromuscular context, there are some additional reflexes you might elicit, such as a pectoralis jerk by striking the pectoralis muscle. And then one other reflex in the upper limbs that I've actually done a full 180 on is the Hoffman sign. So I was taught in medical school that it was not a very good sign based on sensitivities and specificities and positive and negative predictive values and positive and negative likelihood ratios. And I was told, don't bother with the Hoffman sign. I have come to disagree with that more recently. I think it can actually be quite useful in the right clinical context. So, especially if you've got someone who has brisk reflexes, but they don't have other upper motor neuron signs, and your clinical suspicion for an upper motor neuron lesion might not be particularly high. If you do a Hoffman's jerk and it's positive, so it's present, then that is more supportive of it being a truly abnormal hyper-PER reflexia. Whereas if the Hoffman's sign is negative or normal, then I think that's a bit more reassuring. And of course, the combination with other symptoms and signs is important as well. So how do you actually elicit a Hoffman sign? Well, you have the patient's hand just nice and relaxed like this. And what you're doing is you're grabbing the middle digit at the distal phalanx, so distal to the DIP, and you just give it a little flick like this, if you can see that. So you're flicking it into a flexed position like this. And then what you're looking for, the normal response is that nothing happens to the thumb, and the abnormal or positive response is that there's a slight thumb flexion, mainly at the interphalangeal joint, perhaps also at the MCP to some degree, but mainly at the interphalangeal joint, which is time locked with the flicks that you're administering to the middle digit. And of course, you would do that bilaterally. Now, how do you grade reflexes? I would personally recommend just saying the reflexes are hyperreflexic, PER, or increased, or saying that the reflexes are normal, or saying that they're hyporeflexic or decreased, or saying that they're areflexic or absent. There is this plus system as well, which can be used. So 0 for areflexic, 1 plus for hyporeflexic, 2 plus for normal, 3 plus for hyperreflexic. But I think the system is a bit confusing because some people seem to have been taught it in different ways. So I was taught the way that I just described, but I've also seen some people use 3 pluses also being normal and then 4 pluses being hyperreflexic. So I don't think the pluses are that helpful. I'd just say, are they increased? Are they normal? Are they decreased? Or are they absent? Just use your English words. I would somewhat caution against the use of the word brisk because I think it's a little bit ambiguous as to what that means. Does brisk mean that they're just normal and nice, or does it mean that they're hyperreflexic, PER reflexic? Now, how do you actually score the reflexes? So you've chosen how you're going to use your terminology, but how do you actually score them? So an absent reflex is a reflex where there is no visible or palpable joint movement. However, it's really important to recognize that it doesn't count if the skin just wobbles a bit under the strike of the tendon hammer. I've seen so many people try to elicit a reflex and say that the reflex is there, and I can see with my own eyes that the joint didn't move at all, and the reflex clearly wasn't elicited. And what the examiner might have been referring to is just a bit of a wobble of skin. But you could strike literally any part of your own body that's not a joint and isn't where a reflex would normally be elicited, and you're going to get a bit of wobble of skin under there. So if you strike the middle of your thigh with a tendon hammer, it's going to wobble a bit. That's not a reflex. And you could wobble someone who's under neuromuscular junction blockade, or someone who's brain dead or a corpse, and the skin would still wobble. So you really, really, really need to see that the joint moves, or you have an unequivocally able to be palpated muscle contraction under your fingers. So that's relevant mainly for the biceps jerk in the upper limb. So sometimes it might not be that obvious to see the elbow flex, but you can clearly feel the reflex arc being activated and a nice constriction of the muscle and the tendon beneath your fingers as you palpate it. So that's okay. But most of the time you really want to see convincing joint movement. So areflexic or absent means that there is no reflex arc present. Hyporeflexic means that a reinforcing maneuver is necessary to elicit the reflex. So there's nothing without reinforcement, but then when you ask the patient to clench their teeth, for example, you can then bring out the reflex. Normal is normal. There's not much more I can say about that. And then hyperreflexic, PER reflexic, is when there are spreading reflexes. So, for instance, if you strike the joint and the joint appropriately flexes, but adjacent joints might flex as well, so spreading reflexes. Or conversely, if you strike somewhere adjacent to where you would normally strike, and that is still enough for the impulse to spread to the point that you would normally strike and elicit the reflex, and that's also abnormal. So if you strike, say, the mid to distal biceps muscle, and that's still enough to elicit the biceps reflex, and that's hyperreflexic. Pragmatically, one thing that I think is particularly helpful, which I haven't read, but I think it's very helpful, is if you are able to elicit the reflex with an unusually low amount of force being applied, I think that's also strongly in keeping with a hyperreflexic reflex. And what do I mean by that? What I basically mean is if you can elicit a reflex without using a tendon hammer at all, and just by doing a gentle tap with your finger, especially if it's a very, very, very gentle tap with your finger, then I think, if anything, that's probably one of the most reliable ways to demonstrate that a joint is hyperreflexic. And sometimes I've seen patients who are so hyperreflexic that it's almost as if you could sneeze on the joint and elicit the reflex. Like, you literally will touch the joint almost as softly as you possibly can, and that will be enough to elicit a fairly violent reflex. So that's one good thing to be aware of. Now, moving on to sensation. Firstly, I'll just talk about neglect to get that out of the way. Technically, this is a problem not with the arms itself, but it's more of a cortical higher function of the contralateral hemisphere and especially in the non-dominant parietal hemisphere. So what that means is usually neglect is more obvious if it's present in the left side of the body, because for most patients, the non-dominant hemisphere is the right side. So if the non-dominant parietal hemisphere is affected, that's the right side, then it's more common to get significant neglect on the left side of the body. But you can get neglect on the other side of the body as well. In order to evaluate for this, you need to provide bilateral stimulation. I think it's fine just to do light touch when you're doing this. And the patient's eyes should be closed, or at least you need to know that the patient isn't looking where you're touching. So if they're clearly making eye contact and they're not looking at what part of the body you're touching, and you do a little touch and they're not looking, then that's probably okay. But it really is best that the patient's eyes are closed at this point. Now, moving on to the spinothalamic pathways and the posterior column pathways. So you've got two options for the spinothalamic pathways. You've got pinprick and temperature. So pinprick should be using a neurotip prick. Alternatively, you can use the sharp end of a blunt drawing up needle. And then temperature, usually you can just use the metallic component of your tuning fork, because usually that's cold, or alternatively you could use something which is hot or cold as well. It's better if the eyes are closed when this is being tested as well, but again, if the patient isn't really looking where you're testing, then that's probably not the worst thing in the world. Then in terms of posterior columns, you've also got two options here. You've got vibration sense and proprioception sense testing. So for both of these, you need to start distally and then you move more proximally if needed bilaterally. For vibration sense, you use a 128 Hz tuning fork, which are the bigger ones. And there's two ways to do it. If you're worried about the patient not being completely reliable, then you should be doing it with your eyes closed and then ask them to tell you when the vibration stops, and then you deliberately stop the vibration and check that they can reliably say that it stops at that time. That's more time consuming. I'm not sure how helpful it is for a cooperative patient. I mean, if you don't think that someone's going to be dishonest or misleading and you ask them, can you feel the vibration? And they say, yes, I can feel it, or no, I can't feel it. I think that's good enough for me most of the time. Then in terms of proprioceptive testing, the key point here to recognize is that you need to do really, 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 really small movements with the eyes closed. So the main trap that people fall into is they do these like really big joint movements, and that's not sensitive enough in terms of testing proprioception, particularly in the upper limbs. So you start just by moving the DIP and you just do this tiny little movement and ask the patient with their eyes closed to tell you whether you're moving the joint up or down, and then you proceed more proximally if necessary. Now, in terms of light touch doesn't itself really discriminate between the sensory pathways, so it doesn't really discriminate between the spinothalamic tracts and the posterior columns. Some texts do claim that it does to some degree, and they talk about distinguishing fine touch from coarse touch. I find the way that this has been described somewhat inconsistent and not completely convincing, but in any case, I would just recommend sticking with pinprick and or temperature for the spinothalamic columns and vibration sense and or proprioception for the posterior columns. There is also this 2-point discrimination testing. So that's having a special piece of equipment with two fine points next to each other, and you touch them with both points or just with one point, and you ask the patient to say whether they're being felt by 2 points or 1 point. And then you measure how close together the 2 points have to become before the patient no longer can perceive them as being two separate points and only perceiving them as a single point. That's especially useful, for instance, in the context of evaluating for a diabetic neuropathy, although really that's in the context of a neuromuscular assessment, and I can't say that this is something that I would routinely perform in my upper limb examinations. So there are a few tips and tricks when it comes to sensation testing. Firstly, really you should test each dermatome and you should be mindful of the anatomy whilst you're doing your evaluation. And you should also be mindful of key anatomical plexus distributions, so of the trunks and cords of the plexus, and also the distributions of the key peripheral sensory nerves to try and map out and determine whether an area of sensory loss is in a dermatomal pattern, or whether it's in a plexus pattern, or whether it's in a peripheral nerve pattern. However, you also need to recognize that there can be considerable overlap person to person regarding the specific dermatomes. And probably more importantly, there's also considerable overlap between the adjacent dermatomes in a specific patient, meaning that there's redundancy in the dermatome system. So one particular patch of skin on the border of, say, C4 and C5 might have supply by both C4 and C5, so that if you knock out either C4 or C5, the other dermatome, the other sensory nerve root, will still be able to supply skin to that area. So the actual area of sensory loss from a single radiculopathy is typically less than the distribution that it looks like when you look at the diagrams in the textbooks and online. And also, you may just get hypoesthesia as opposed to complete anesthesia with a radiculopathy. So you just need to bear that in mind. The other thing I'll say here is, in terms of speeding things up and balancing competing priorities, and we're all time poor, based on the clinical context, I don't think it's completely unreasonable to do a brief distal screen of sensory testing if you're really not considering a specific neuromuscular problem. So if you're seeing a patient who is having losses of consciousness and you're reviewing them in a first seizure clinic, or you're reviewing a migraine patient, is probably not your top priority to evaluate sensation in the C4 dermatome and the C5 dermatome, given that you have no clinical concern whatsoever for myelopathies or radiculopathies or plexopathies or focal peripheral nerve lesions. That's not why the patient is with you. So you could cut a corner just by testing distal sensation. Don't do that in your exams, but it's just a practical point, so you can take that or leave it as you see fit. One other key point is not to overinterpret minor asymmetries. So I do not think that it's helpful to routinely ask patients for a percentage difference side to side. So if you say, is this side the same as the other side, or is there a percentage difference between this side and the other side? The response that you're almost always going to get is, it's about 90% of the other side response. And I would argue that that's basically completely insignificant. I would frame the question differently. I would recommend testing and asking, were both sides about the same? Were they similar? Were they more or less the same? And then you're more likely to get a yes response unless there actually is a true significant difference between the sides, in which case the patient should still say, oh no, actually the left side was significantly less than the other side. The same concept is true when testing proximal compared with distal aspects on the limbs. So if the distal sensation is more or less the same as the proximal sensation versus if there's a significant difference, that's what you want to know about, but you don't really care so much if there's a 2% or a 3% difference, because that's probably the patient overthinking it or trying to please you or trying to give a very thoughtful answer, but it's actually counterproductive and it's not really helpful. One other question that I get asked often is, do you really need to test pinprick and temperature sense? And do you really need to test vibration and proprioception sense? Or can you just do one or the other, given that they respectively test the spinothalamic tracts and the posterior columns respectively? So the answer to this question I would give is, if you're just doing a general neurological screen in a non-neuromuscular context, so for instance, if you're seeing an epilepsy patient or a migraine patient, I think it's relatively low yield to be testing all four modalities. So I usually just choose one from each of the two groups. And in practice, I've got a tuning fork on me. So I usually use the tuning fork to measure temperature and to measure vibration sense. And that's nice and quick and efficient and reliable and accurate. However, in the specific neuromuscular context, so if you're specifically clinically evaluating a patient with a concern regarding a neuropathy, whether that be a polyneuropathy or a mononeuropathy or a plexopathy or a myelopathy or something specifically affecting the sensory pathway in the limbs, then I would strongly argue that actually, yes, you should test all four modalities. And the reason for that is I have firsthand experience many times working in a neuromuscular clinic last year that it's not uncommon for there to be a discrepancy between the two, even within the same category. So it's not that unusual for the patient to have normal temperature, but to have abnormal pinprick. And it's not that unusual for a patient to have normal vibration, but abnormal proprioception, or vice versa. I'm not sure what the explanation for this is. It must have something to do with the underlying pathology and the way that it's affecting the different components of the fascicles of the nerve fibers. I can't think of any other explanation, but I would argue that just based on empirical evidence, based on experience, that sometimes patients do have a discrepancy between those modalities. So you do increase the sensitivity of your testing by testing all four modalities. Of course, it's more time consuming, so I think it's reasonable to do that on a case by case basis. Now, coordination testing. There's a few things that you can look for here. The first is dysmetria, so that's assessed with finger nose testing. And what you're looking for is you're looking for true pass pointing. And you're also looking for an intention tremor because that's also indicative of cerebellar dysfunction or dysfunction of the cerebellar connections and outflow tracts. And of course, just a quick anatomical point, remember that cerebellar dysfunction manifests ipsilaterally as opposed to contralaterally to the cerebellar lesion because the outflow tract pathways decussate twice. So they don't just decussate once in the pyramids like the corticospinal tracts do, and they don't just decussate once like the corticobulbar tracts do, they actually decussate twice. So it's like a double negative and it cancels each other out. Now, in terms of actually testing finger nose testing, one trap that I see people get wrong is they don't test it at the full range of movement. So the target that you provide for the patient needs to be with the patient's elbow totally extended so that their arm is completely outstretched so that they can only just reach the target. Otherwise, if your target that you're giving them with your own finger is only at the midpoint of their elbow extension, you may get false negative results because you're not testing in a way which is sufficiently sensitive. So you really need to get the patient to reach out for your finger. In terms of moving your target, so moving your own finger, I like to move it in between each test. So what I like to do is get the finger to do finger nose, back to the nose, and then I move my own finger and give them a new target to work towards each time. Obviously, if there's any visual field deficit, I make sure that I'm testing it within their normal visual fields. Some people don't move the target at all, and so the patient's just going back and forth between the same target each time. I personally don't like to do that. I feel that you're probably increasing the sensitivity of your testing by giving them some new targets to work towards each time. I can't say that I've got a paper to back that up. Maybe someone can tell me if they do have a paper showing that it is or it isn't helpful to move the target, but I'd recommend moving the target. One other thing that I do see some people do is I see them moving the target within each test. So the patient's going towards the target and then the examiner quickly moves their finger. And so the patient has to correct the trajectory of their movement partway through to then reach the new target. That can also be done. However, you're then starting to test something a little bit different. So that's then a test of ballistic correction. I'm not sure that that's especially helpful and additive in your overall assessment, so I don't routinely do that, but some people do like to do that. Now, the other thing that you can do in terms of assessing coordination is testing for dysdiadochokinesis. So the recommendation that I would give here is ask the patient to actually make an audible slapping noise with each volar and dorsal surface strike. And the reason for this is it makes me know that the patient is actually performing the movement properly rather than just rolling their hand back and forth on their palm. So what I mean by that is you ask the patient to make a slapping noise like that so you know that the patient is actually lifting their hand up, flipping it over, placing it down, and repeat like this, as opposed to if they don't make a slapping noise, they might just be rolling the hand like this, and that's not actually a test of dysdiadochokinesis at all. I have heard some people define what a normal number of correct hand claps is in order for someone to not have dysdiadochokinesis, and the number I normally hear is 10. Although I wouldn't say that this is commonly stated, and you do just get a bit of a general feel for it with time, and it's important to compare side to side as well. Although a trapezius bilateral cerebellar pathology could cause bilateral dysdiadochokinesis and bilateral dysmetria, so both sides might look about the same, even though they're both very impaired. One other test you can do as a test for coordination is alternating fine finger movements, and there's a few different ways you can do this. You can do like this, or you can do these ones. So for those that are not watching the video and are just on an audio podcast platform, rapid alternating flexion and extension of the MCPs in the second and third digit in an asynchronous manner, or flexing the MCPs of the second, third, fourth, and fifth digits to make a pincer grip with the thumb in an alternating fashion in a quick way. So that is also a test of coordination, but it's less specific and it's less discriminatory because it also combines other pathways because it involves the extrapyramidal systems as well. So it can be impaired, yes, in a patient who has a cerebellar problem with dysmetria and ataxia, but it can also be affected by bradykinesia. It can also be affected by rigidity or weakness. So this test does have its place in clinical practice, but it's not as targeted towards the cerebellum, and it's not something that I routinely choose to do in my routine upper limb neurologic examinations. So this is the last slide of the presentation. Now that I've been through all of the components of the upper limb examination, I'd like to just tell you how I do it because it's faster this way, but it's out of order. So I wouldn't do this if you're in an examination because, again, your examiner will have a stroke and think that you've forgotten something and you'll put them in a negative mindset, which is not the way that you want your examiner to be thinking of you. But just in your routine daily clinical practice, I personally find that mixing up the order a bit makes the process faster and more efficient on the whole. So I start with inspection and palpation, if palpation is necessary. I then go into tone and power. But then, whilst I'm still on the motor system and not using any equipment yet, I do coordination. I then go on to sensation because that requires equipment, and I get my tuning fork out and I do my temperature testing and vibration testing and a quick screen for neglect with light touch testing. And then I reach for my tendon hammer to examine reflexes. Also because, I mean, it shouldn't be uncomfortable for the patient, but some patients might find it mildly uncomfortable. It's probably more relevant for the lower limbs that I do the uncomfortable thing right at the end. And just out of habit, I do the same thing in the upper limbs as well. So you don't need to take this advice as you want. This isn't a big point at all, but it is just a small suggestion as to how you might like to quickly speed up your examination. But the important part of this episode has been the tips and tricks with each of the individual components of the examination. So that's it for today. Thank you for tuning in. Please like, comment, and subscribe if you found this episode helpful. Visit ourneurologyeducation.org for all of our media formats and additional content. Find our videos on YouTube and our audio podcasts wherever you listen to your podcasts, and find us on your preferred social media platforms as well, all found at the domain R Neurology Education, and that's R with the letter R, or email us at contact@ourneurologyeducation with any questions or to subscribe for updates. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.